So what I'm now going to do is change gears and go through a few examples to give you a diversity of the challenges, possibilities, opportunities with the idea of what we are trying to do to bring these kinds of thinking, these kinds of technologies to really not only understand the biology, but how to improve on some of the existing problems and challenges with the drugs that are in the current market. And I'm going to use heparin because heparin in many ways could be viewed as probably the most interesting natural product because it's been around for the last 70 to 80 years. It was discovered by accident to have an anticoagulant function, used in the clinic as the most safe natural product with minimum modification, but yet it's a fairly complex mixture that, as I showed you with a few earlier slides, we truly don't understand some of the nuances of how various sequences correlate to function. So I'm going to focus on an area of application, which is ACS, that all of you might know, which is essentially acute coronary syndrome, which essentially comprises of the unstable angina and acute MI, where the atherosclerotic plaque leading to a rupture eventually lead to a clot formation and in anything downstream. And heparin is the drug of choice that's being used in the ACS setting because of its anticoagulant function. So when you go into an emergency room, a patient entering the ER with ACS is given either heparin, which is this fairly complex, highly heterogeneous mixture, or low-molecularweight heparin, which is essentially putting heparin in a blender and trying to reduce its polydispersity to a smaller extent. And the idea is, how do you look at the variety of downstream events of medical management, PCR, or CABG, because ACS is probably the most challenging and the difficult management that you could ever think of, because the attributes that you need to have for this is enhanced arterial efficacy, full reversibility, few bleeding complications, ability to monitor your drug, and finally a predictable PK, and ease of use. And these are fairly difficult things to achieve, and in some sense heparin has, because of its historical role, been able to play a satisfactory role in the ER. So when we ask the question, how does this really work? How does this complex mixture, where 10% of this mixture essentially has a sequence that binds to antithrombin 3, which eventually binds to thrombin as a way to dramatically activate the clotting cascade, as a way to inhibit the clot formation that is downstream in ACS. And the idea is the following. Here's the basic pathway. There are two pathways, the intrinsic pathway and the extrinsic pathway, one by tissue damage, the other by trauma, that converge. And heparin plays a role in this point that I'm going to come to in a minute. It's activated by prothrombin to thrombin, and thrombin feeds back into a variety of these upstream events to eventually regulate the clot formation. And what heparin and low molecular weight heparins do is that they regulate the antithrombin by dramatically forming a complex and kinetically affecting the convergent common pathway and hence thrombin, and feedback into a variety of these loops as a way to regulate the process of coagulation. It's important to point out that one of the limitations of heparin is it does not really touch the common pathway and the extrinsic pathway, which is one of the serious limitations of this molecule in the clinic. So what we came about, and I'm going to come to that in a minute or two, is using a variety of our techniques of getting to the structure function of these mixtures, understanding the distribution of these moieties in this mixture, how to tailor make a molecule that could not only access all these different pathways, but also address the issues of some of the limitations that I spoke about. So the point being, could you then design a molecule that would not only activate these two common pathways, but eventually regulate the thrombin by blocking the entire cascade? The long and short of it is, because we developed a whole host of enzymes, and these were the earlier studies that my laboratory did through funding from NIGMS, was generate a set of enzymes that very specifically access the antithrombin 3 binding site in this mixture. And since we could study this mixture as in terms of the various chemical components, we were able to generate a specific set of heparin moieties that have both the 10A and 2A binding site. It also had a constant ratio between these two, which is very important. It had the reduced polydispersity that limits both heparin and low molecular weight heparin. In many ways, you could view this as it had the best of attributes of heparin and low molecular weight heparin, and it removed the bad attributes of both heparin and low molecular weight heparin, so that it eliminated unnecessary sequences or sequences that caused side effects. So we showed through both a rapid model in terms of increasing the arterial efficacy, but most importantly, the ability to neutralize this, because that was one of the key things that is needed in the ACS setting, where this particular molecule was fairly effectively neutralized, comparable to unfractionated heparin, but low molecular weight heparin does not. Low molecular weight heparin cannot be monitored. Heparin can be. Low molecular weight heparin cannot be neutralized, but heparin can. But heparin has bleeding problems. So long and short of it is, here's a summary of what we try to generate compared to the other molecules that are there in the clinic, and showing that you can actually access this complex mixture and really dial in, if you will, attributes that you really want into it, such as enhanced efficacy, full reversibility, few bleeding complications, ability to monitor, and to be able to have an ease of use with regard to predictable PK, because heparin truly is limited by that. So the point really being, once you understand the structure activity, once you have the tools and techniques to be able to think about this problem in this fashion, you can take current molecules and truly improve them and get to the heart of the structure-function relationship. So this particular molecule, an IND has been filed. The first patient was dosed earlier this month, and the clinical trials are ongoing to really evaluate whether this would be a viable candidate for ACS setting replacing heparin.